Hi, I'm Chris Mostert. I'm a physician in the Department of Medicine, Coffs Harbour Hospital. I've got two videos that I'm going to talk to you about. One, the fundamentals of drug therapy in COVID, as well as other modalities of treatment. And in the second video, I'll be covering how to get through the various forms for COVID-specific therapies. So let's move on to the main concept of this first slide is once the patient has contracted COVID, they go through a pre-symptomatic phase with viral replication escalating and viremia occurring. Then as they become symptomatic, over the next few days, the viremia in actual fact will then be declining. So this is actually not the dangerous phase of COVID. It's this junction here where either the patient would be recovering, meaning that the inflammatory response will be tapering down as well, or for the patients that now will go from mild to moderate to severe illness, this is the critical phase here. So it's an overlap of at least 5 to about 8 days. So this is the careful balance between a pro-inflammatory state versus a inflammatory state that has served its purpose and now cleared the virus but is settling down on its own. If we have an ongoing inflammatory state, this is the one arm we should treat. On the other end, however, earlier in the disease, we aim our therapies at suppressing the virus. So let's have a look then how we do that. So antivirals in the first part, quite important. We have the monoclonal antibody Severity, which is designed for outpatient treatment, directed at the virus, and this is for high-risk patients in the context of progressing to severe COVID disease. And these are patients that are not vaccinated or they are vaccinated but have a suppressed immune system. There is a particular formula for that, and we'll discuss it in video 2. Remdesivir is an antiviral agent, comes from the days of developing hepatitis C therapy, but did not reach the arena for that, but is most certainly useful in COVID. Having said that, it's not, for example, as potent as dexamethasone in altering outcome. And then later in this year, we will have other therapies, which is important in the form that it'll be oral, so we don't need intravenous infusions like Severity, and it'll be for community-based patients. In other words, reducing the severity and progression to severe illness. So this is actually very handy when that becomes available. Keep patients away from the hospital. So dexamethasone is when your patient does need hospitalization on clinical merits. So Severity, you'll, for example, use in the ED for a patient that may have social reasons to be in the emergency department or they've come in from the COVID in the community observation team. You've decided they can go back into the community, but they may benefit from Severity. But you're now in ED and you've decided that this patient needs to come in. So dexamethasone is going to be required because the patient has an oxygen requirement in all likelihood. We'll have a look at that in a moment. Baricitinib is a JAK2 inhibitor, potent anti-inflammatory agent used in rheumatological diseases. Then you have tocilizumab, one of the old stalwarts, and this medication is a interleukin-6 inhibitor and is very useful in patients that are severely ill or as an alternative agent to use in pregnancy. Then you've got your oxygenation tools, which is not really the scope of this talk. What I would like to highlight though is prone positioning is probably underutilized out of observations from Coffs Harbour patients, so especially in the emergency department. We'd like to see those patients be put onto prone, and we're not talking about the complex proning of patients when ventilated for ARDS. We're just talking about getting them onto their belly. And in that way, that actually improves the oxygenation status of the patient. DVD prophylaxis is very important. These patients are hypercoagulable. Up to 50% of patients have PEs in 2020. And we may even need to use high dosages in the future, but standard dose prophylaxis at least. And then consider PPIs when we talk about prophylaxis as well, because remember, you're going to give this patient a dexamethasone medication in all likelihood. The patient's physiologically stressed. PPI is definitely worthwhile considering if you think about you already introducing heparin as well. Monitor blood glucose levels because of the dex, and that is then for the medical team to sort out if that happens. Right. So with that in mind, I'm just going to take you through to the ACI guidelines. So this guideline is available on one of the links below my video. It's a very useful guideline. It's a very succinct summary, which is still relevant and has been reviewed in December. Now, I'm going to skip to the part that really is important in the 2 pages, and that is the severity and then the marrying of that to the medical therapies. So you've admitted the patient because the patient has an oxygen requirement. You're able to maintain the saturation above 92, and this is with oxygen, low flow, nasal cannula. The patient is within physiological parameters, okay. So what do we need to do for this patient that has some moderate disease? So we're definitely going to give dexamethasone. I tend to give 6 milligrams intravenously, and later on I'll step down to oral agent, because I do not have an idea as to how well the patient is absorbing at that point in time. And why would that be? This patient may not be perfusing the gut like they normally would, and the usual physiology may not be in place. So I would rather give intravenous therapy to start off with and later on oral agents. The other agent you have to start is remdesivir. And the reason for this is what we discussed in that slide there. So you may well be still in this phase here where the viremia is still lingering high enough to get good therapy. So the trial on remdesivir included all the way up until 10 days. Probably you're going to max out at day 7. So the return on investment is going to be less after day 7, I would imagine. And remember, it's not that potent a change in outcome. Right. So you've done double therapy. What about this one here? Because it says start here as well. It's not that easy though. So we don't use baricitinib right at the start. If a patient continues to deteriorate despite these 2 agents, then I would say baricitinib is useful. And what are we talking about deterioration? So you want to know that the patient is in a pro-inflammatory state, so you want a CRP of more than 75, and not, for example, the patient has a low CRP but has PE, so that would be a reason that patient is deteriorating. So what you would want to do here is use baricitinib if you're not getting the patient stabilized on double therapy. So the triple therapy follows on later in the disease course, and potentially the patient is heading high flow nasal prongs route. So if the patient is moving towards that side of things, baricitinib is most certainly a yes. And then what about tocilizumab? So I don't think out of an ED department, most of medicine patients would be thinking tocilizumab. We'd be thinking of that as an alternate in pregnancy. So alternate to what? To baricitinib. And we do have a shortage of tocilizumab, but we do have it available, so we want to use it carefully and judiciously. And the other group is the mechanically ventilated patient, because you're not going to start with these agents here. You are going to continue if you have already started, but you'd rather be using dex and tocilizumab to really slam on the brakes on the cytokine storm. So hopefully that makes sense, and that gives you a guide to what you start from the emergency department, whether you're the ED clinician or whether you're the medicine clinician that has received the consult. And I mean, I think the important part here is to realize that if you have your dexamethasone on board, you have your oxygenation tool on board, you've got your DVT prophylaxis on board, those are really the main fundamentals of treatment to get into place early on. And if you're uncertain about the other agents here, that then can go to an ID consultant and they can get back to you as to what is the next step. So get the basics right, and so the fine tuning of baricitinib and remdesivir can happen later on. And that probably is true then as well for your pharmacy applications for getting the remdesivir, for example, and the baricitinib. If it's in the middle of the night, there's no big difference in getting the paperwork done and getting the pharmacist out and getting that all done before the next morning between 7 and 9 o'clock. If that patient can, if you can send off the forms, and I'll show you that in the video too, and the pharmacy get that the next morning and they dispense that first thing, that's fine. We're talking about hours, yeah. If you go according to Aci Guidelines, getting all the basic stuff right, that's most important in the first 3 hours versus 6 hours. But if you just have to add one more ingredient on, I'm quite okay if that happens at the first thing the next morning. If it's 6 p.m. in the night, that's a different story. Right, so that's part one.